Hello and good evening, and welcome to the second ERS educational webinar. And this evening we are talking about the frontal sinus. What webinar series wouldn't be complete without a talk on the frontal sinus, of course. This area continues to challenge us, both in terms of decision making and our surgical skills in that area. And it's a real pleasure this evening to welcome three senior colleagues, all with extensive experience in managing frontal sinus cases. We have Anshul Sama, who's an honorary professor at the University of Loughborough and consultant in Nottingham here in the UK. We've got Cem Meco, professor at the University of Ankara, and who's also president of the European Confederation of ENT Societies. And Ioannis Constantinidis, who is the president-elect of the ERS and who is president and chairman of the Aristotle University in Thessaloniki. And of course, as ever, I've got my colleague Pavol Surda, president of ERS Juniors, who is standing by as well. So just a reminder that the views expressed are those of the faculty, and not necessarily of the ERS. And at the end of the meeting, of course, we'll have a Q&A session. So please log in your questions. We'll present them anonymously, so you don't need to worry about having your name read out. And we look forward to all these questions. So without further ado, I'll pass over to Anshul, who's going to start the presentation.
Thank you very much, Sean, for this kind invitation and the opportunity to share my opinion on one of my favorite subjects, the frontal sinus surgery. And thank you very much for the organizing committee as well. So my remit was to talk about managing the frontal sinus in key decision making. So in 15 minutes, I'm going to try and cover this. Now, traditionally, I always start with something like this, because they're the different challenges that frontal sinus often present to us. However, at present, I think the biggest challenge that presents to us is this virus and how that has entirely changed our life, and also to some degree how we're going to approach the frontal sinus in our decision-making and surgical mechanisms. So I did a literature search on COVID-19, and in the last 6 months, we have had 22,499 publications on COVID-19. Comparatively, if you look at how much been published on frontal sinus in the last 5 years, 2,464. So you can imagine there has been a huge amount of publications in this area. But if you combine the two, actually, there's only one publication that seems to correlate both frontal sinus and the COVID-19. Well, that's obviously not entirely true, but that's what it shows. So going back to what Sean is saying, this is really cannot be based on science, though, because although we have 22,000 plus publications, we really don't have an evidence base of what we're going to be saying. So it's really an opinion that I'm providing, based on my understanding and read of what is happening in the COVID-19 era. Additionally, the key thing we always think about is what is the most appropriate management for a frontal sinus disease, whether it's an osteoma, inverted papilloma, or inflammatory disease, whether it is medical management or whether it is to do with what kind of surgical intervention. And at that point, I would often just present my mantra, which is, you look at the pathology, you look at the anatomy, and then you decide on the approach and the procedure you need to do. But at present, all of this is somewhat superseded by the fact that we have to consider additional factors on top. And one additional factor, patient safety, always the issue, but here we have a very different patient safety issue. Patient safety in the COVID era, and also we have to look at the staff safety. And at the same time, if you look at the different factors associated with this, it complicates the whole process of our decision making, from the preoperative isolation to assessments, how much false negative tests we're getting, how do we protect the patient through their journey through the hospital, how do we protect the staff, do we use a drill, How do we isolate the patient post-operatively so that they don't get infected post-surgery? And how do we manage them in an outpatient arena afterwards? And if you look at all of this, you could have two potential reactions. You could either do the ostrich technique and just bury your head and say, I'm going to ignore it all. Or you could take the other extreme and say, I give up, this is too much, I do not know what to do. And I think the answer entirely lies somewhere in between. It's a balance between the two. You cannot just stop, you have to offer a service. It's making the right judgment. Now, if you go to the associations and see what they have put out there for us, this is the American Academy talking about what kind of rhinological services. And if you look, they tend to categorize them into three categories: urgent, time-sensitive, or routine. And the time-sensitive and routine are very much based on impairment of ability to work or perform. So it's very much a quality of life-based assessment of their recommendation. And most of what we're going to do in frontal sinus surgery falls in the middle here in what would be called the time-sensitive zone. If we then look at what we do in UK, it's very much based on the guidelines from the college, which are the priority levels. And this is very much based on temporal basis. How long can you leave this condition before it becomes problematic? And it goes from emergency to urgent to priority 2, 3. So most of us procedures that we do electively will fall between 3 and 4, with the exception of a few emergencies. But this is the temporal-based decision-making. And then if you look at what the French have done, have actually very much identified a collaboration of the two, but also put in their recommendation of what to do. So the group A is the emergency, and the two pertinent areas here for us is sinusitis with complications, where the frontal sinus will often be involved, and mucocele. And mucocele frontal sinus is the commonest site for mucocele, which they say with some neurological or ophthalmic sign. Now that's interesting. That can be interpreted in many different ways. But for them, that means an emergency procedure. Then if we look at group B and C, most of the pathology that we would deal with, including tumors, fall in that. But their stance on this is to postpone surgery. So if you've got somebody with inverted papilloma or mucocele without compression, you postpone the surgery and follow them up on a monthly basis in group B, and then 6-weekly basis on group C. Now that's probably not sustainable in a lot of practices to have that kind of a follow-up process. And I think some of these individuals probably will qualify for intervention based on their other factors rather than just the fact that that is what they fall into. So no system really is ideal to follow. The difficulty I have with these recommendations is that sometimes the answers are very clear. Here's an osteoma, unilateral osteoma, grade 3 osteoma, no real pathology beyond. I think most of us would say, well, we'll sit tight, we'll watch. This is a slow-growing tumor. We really don't need to intervene. We'll do some interval scanning and we'll see the patient. Conversely, you've got same pathology, but behaving very differently. And this patient presents with meningitis because of this osteoma, having this protrusion into the cranial cavity, but also having quite a significant progressive compression of the orbit. And you would say, well, this patient does require surgery and is in the urgent or soon category. And you would have no concerns about that decision making. What becomes difficult is when you have the borderline cases. So here you have a patient who has a smaller midline osteoma, very accessible through an endoscopic approach, but has some pathology lateral to it, but there's some air in that frontal sinus as well. And does this now patient fall into, they are compromised and there is a potential for damage to this individual, or does this fall into a watch and see category? And this is where the decision making will vary a lot from individual to individual, from different geographies and different threshold of what your normal practice norm is. So my recommendation in this particular area is you need a multidisciplinary approach. Now we talk about this yet in the last presentation when Paolo Casanova talked about multidisciplinary approach for skull-based tumors. But this is also very important, because when we are making decision in these gray areas, what we really need is sharing of blame, sharing of decision making. We need to be able to actually communicate with a group of friends around us and make a joint decision so that we feel that we are doing the best for our patient. And why is it important that we do the best? Because times have changed. This is a paper that looked at 235 different hospitals over 24 countries with 128 surgical patients. The 7-day mortality of this group was 5%. The 30-day mortality was 24%. Now, I acknowledge that only 3.5% of these patients were head and neck patients, but one could interpret actually headache is a higher risk area, so potentially these figures could be more aggressive in this infected field than it shows out here. And they in particular pointed out that men age above the age of 70, if it's an emergency procedure or if they have an AS grade greater than 3, at a higher risk. But a simple other concept here is very valuable. If you have no comorbidity, your risk of death, mortality, was 7.4%, quite substantial still. If you had one comorbidity, just something like high blood pressure, your mortality rate jumped up to 18%. And if you had 2, say asthma and hypertension, it's up to 30%. 1 in 3 individuals in this group succumb to this. So I think it's important for us to protect our patients from these figures and make sure that we advise them of it. Some institutions have tried to create a kind of a logarithm to try and assist you looking at patient factor, procedure factors, disease factors, and kind of give you a numerical way of scoring and identifying this and then validating it. I think that's feasible, but is it really applicable to everybody? Because a lot of these things are interpretable. The other aspect we need to look at is protecting our staff and ourselves. And what is, there's some data out there looking at the degree of spillage, aerosol exposure that you get related to surgical procedures. And the 2 papers, this is one of the ones we saw originally, and this is 2 cadavers with fluorescein injection with different types of procedures, including frontal sinus drill out, sphenoid procedures, and sinus procedures with different types of burrs. Overall, it seems to suggest most procedures are safe, with the exception of using a diamond burr in the sphenoid or a cutting burr in the beak, or actually having the burr outside of the face. Now, oddly enough, some of there's disparity, because how is it that a diamond burr in the sphenoid creates more aerosol than a diamond burr in the frontal beak doesn't? But conversely, a cutting burr in the frontal beak generates more aerosol than a cutting burr in the sphenoid. I think we're limited by the quality of the study, and there's small groups here. So converse to that, here is another group that looked at all drilling procedures versus cold power and showed that all drilling procedures generate an aerosol. So there is a high risk related to any kind of drilling procedure within the airway. There's good evidence if you use cold steel or microdivider, you're probably safer. Now, when it comes to looking at different types of pathologies, now I don't think anybody would doubt or question the role of surgery in acute frontal sinus conditions, orbital cellulitis, Potts-Buffet tumor, or intracranial disease secondary to that. Question sometimes comes, what do you need to do in this situation? And for me, I have always considered incision and drainage. When you got pus, you incise and drain, and that's what we should do with orbital disease or other inflective diseases or sequestrum secondary to sinusitis. The question then is, how much sinus surgery is really necessary in these acute complications? And it is my opinion as a rule, and has always been, that in acute frontal sinus disease, drainage is all you probably need to do. So my most common approach to this is trephine, culture, drain, irrigate the frontal sinus, consider leaving a drain or IV antibiotics, but no endoscopic procedures in a hot frontal sinus. It is often likely to lead to trouble. This is the commonest. I tend to prefer the mini trephine, but you could be looking for a different way of doing the same procedure. And you can see that actually it's quite a simple procedure to create an opening into the frontal sinus with minimal degree of aerosol generation, because you're entering a very small pocket, and you can then put a cannula in there which allows you to irrigate or ventilate or put medication directly into the frontal sinus. Gives you access to treat the patient subsequent to that. Just a small cannula goes on top, and you've got yourself a portal of entry into that sinus, which is very helpful. That would be my mainstay of therapy. Word of caution: when you've got chronic facial swelling, cellulitis, fistula, as you can see here, from previous incision surgery, do not try and do sinus surgery in these patients, because it will close down on you. When you've got such a high inflammatory load, it will always close down. I would go conservative, antibiotic therapy in these situations. A few other pearls I'd like to leave you with facial pain. If you've got patients with facial pain, which is very common with people who have frontal sinus disease, we will often associate facial pain with frontal sinus disease. And we know from our experience, and especially Nick Jones, my colleague, did some extensive work, which showed actually facial pain is only associated with sinusitis in a minority of individuals. 16% of patients had facial pain related to sinusitis. So if you've got a patient with facial pain as their primary symptoms, be cautious. The second thing is, if the symptoms, diagnosis, and revision surgery, these are concepts that we always use, but actually are much, much more important, because the risks to the patient are much higher. The risks to the staff is much higher. Always think about something else. And here, if you've got people who have had repeated infection, think about immune deficiency, mucocele clearance, vasculitic disease. And we have lots of evidence where we see over the years where people have identified high prevalence of immunodeficiency in these individuals. And if you've got a revision case, I would strongly advocate that you need to look for immunodeficiency. The last point I'd like to leave you with is the role of really aggressive medical therapy. This is a time where I think we have to be very aggressive with medical therapy. Let me share with you some of my experiences of individuals who haven't been able to operate on because of medical health. And so this is the patient who's obviously got bilateral disease, chronic. You can see osteotic changes within the frontal sinus, thickened bone, and then you've also got dehiscence and a lateral mucocele. And traditionally, we would say that this is a surgical case. This is not something that would be managed medically. And if you look at that, there is obviously an isolation and some dehiscence into the intracranial cavity as well. This individual was managed medically with aggressive 6 to 8 weeks of antibiotics, topical steroids, anti-inflammatories, and this is the outcome that was evident after that. You can see that actually medical therapy can sometimes resolve issues that you may not think is eminent, but also think about when you've got inflammatory disease versus obstructive disease. They're two entirely different things. There are few frontal sinus cases where it is an obstructive event due to an outlet flow disorder. A lot of them are usually inflammatory and systemic, related to eosinophilia, aspirin sensitivity, allergies, and there you should be treating the primary cause more aggressively than the pathology that we see in the sinus. Another example of somebody who you think would be an ideal candidate with what looks like an expansile maxillary sinus with some dehiscence in the frontal sinus, and you can see also some intracranial bleeding because of a lateral mucocele. And if you treat that, this is the same CT just to show you whether there is any mixed densities within the maxillary sinus. Treated aggressively with medical therapy, and you can, excuse me, resolve this problem, even though it looks primarily surgical. So, key messages I'd like to leave you with. I think emergency surgery, in my opinion, do as little as possible, but must address the pathology. Frontal trephination is to me, is probably the workhorse, and it would be very interesting to have a chat about how much sinus surgery should we really do in this acute situation. I think you need a structured approach to prioritize what you consider is really important and needs addressing. We have guidelines out there from institutions. Your practice is what you will need to assimilate those guidelines and make a judgment. And I would encourage you to get other people involved in your decision making when you're approaching this problem, because this is now a difficult, complex time and area. Beware of frontal pain and look out for immunodeficiency. Be aggressive with your medical management. An appropriate approach and level of surgery is what is required now more than any time in the past. I think avoid drilling as much as possible. You can achieve as much as keratins and cold steel than you need with a drill. A 2A procedure is going to address 90% of the pathology that you're dealing with without the need of drilling. And lastly, if I may take this opportunity just to say, please look out for this book that Christos and myself have put on frontal sinus surgery, and I hope you would like to see more about frontal sinus surgery from this. Thank you very much.
Anshul, thank you very much. That was a very nice introduction to the problem that we have during this pandemic. I'm now going to pass on to Cem, who's going to talk about the role of endoscopic approaches. Can I just remind everybody that we're collecting questions as we go along. We're not doing a chat function, so if you can pop your questions onto the Q&A, we'll come to those at the end.
Okay. Oops. Do I have the, okay, share screen, perfect. Okay, do you see Sham?
Perfect.
Okay, thank you. Good evening, ladies and gentlemen. I also would like to thank ERS for this kind invitation to this webinar. Professor Sama have already summarized how we should make our judgment to operate on frontal sinus in the COVID-19 area. So I will not be focusing on that. My topic will be, once we decide to operate on that patient, how can I operate safely endonasally? So I have, first of all, nothing to disclose. And I would like to mention that actually nowadays we are utilizing endoscopic frontal sinus surgery for many things according to our continuously evolving management protocols. And we have actually well-established surgical techniques. In this talk, I'm not going to talk about the techniques, the endoscopic techniques. These we utilize in many of them. But even for the very far lateral pathologies, by suspending the periorbital laterally, we can transpose orbita and reach to the really very far lateral corners of the frontal sinus. So we have these capabilities today, and our goals are to eradicate the pathology, to create an access route for our medications, but also for watching out the pathology if it's coming again. And we always try to have a long-term patency. Unfortunately, we have this pandemic. In the beginning, we thought that it is really far, far, far away, like it was with the SARS and MERS, but eventually it became a pandemic. So we have been all affected, including Turkey, where I'm now based, around 1.5 months later than Italy. So every country have their own curves. In the history of pandemics, actually, the humankind have many other pandemics, and COVID-19 is not as big as the other ones, but it is exactly the time in the time frame where our endoscopic surgeries have been invented and we're using. So we really have some unprecedented challenging times. We all know that this virus is highly contagious. It's a microdroplet infection. Our main issues are the droplet and the aerosols that we are producing during our examinations and endoscopies and surgeries. Normally, with the masks, we can cancel the aerosols, and with hand washing and social distancing, we can manage in our normal lives this virus. But in our examinations, these aerosols, they do hang in the air for around 3 hours. And we also have the problem that we have a 30% incidence of patients without having symptoms, but they're contagious for 14 days without any symptoms. And in the beginning, there were problems with the testing, and there were we had some super spreaders. And at the end, as of today, we have more than 8 million infected patients and more than 436,000 global deaths. So in the beginning, our primary concern was to flatten the curve. And like everyone, we really stopped all elective cases, only malignant tumor surgeries. We just do the lockdowns and still stand in this chess game to save lives. And we were a little bit lucky in Turkey because of the young population. Up to now, we only had less than 5,000 deaths, although we have 83 million population. But the bad news came with this paper, actually, from Stanford Group. They were warning us about the multiple members, more than 14 of the patient care team during an endoscopic procedure, both within and outside the operating room, who became infected from what became later on recognized as COVID-19. So this is the beginning of a new era for endoscopic surgeries, or at least for some time. So naturally, many groups, they try to develop some strategies to control the source during their examinations and endoscopies. And for emergent operations, there have been some strategies to use the microscope drapes with limited instruments inside, if you really need to operate under these conditions. And as Dr. Sama have already shown this publication, we have developed some masks that enables endoscopy and are as efficient as the surgical masks. But the same studies have also warned us that our surgeries, our aerosol generating surgeries, especially if you're using the high-speed drills. Some further studies have been also made that the transnasal drill and the cautery are everyday tools almost nowadays. All of a sudden became significant airborne particulate matter production tools. Thanks God, the normal endoscopy, speech and sneezing were not that bad, but these studies have shown us that the standard surgical masks will not be protecting us. Though another study has shown that the endonasal drilling may be employed safely because they couldn't really reproduce the same results while they had using the drills. So the Pittsburgh group have mentioned that the use of high-powered drills is not contraindicated, but may be employed safely with good technique, like using the coarse diamond burr to minimize aerocolate bone dust, frequent irrigation, and prevent burning bone, and constant suctioning seems to be very important. So another study have investigated the droplet and splatter patterns, and they have shown that the concurrent suction is really helping us if you really need to use the drill during an endoscopic procedure. Another study have been published by the group from San Francisco. They have been trying to do some kind of a negative pressure otolaryngology isolation drape. So they were trying to suction the aerosols that are produced before they reach the surgical team. So apart from these source control strategies, another strategy could be the environmental control setup, because the aerosols can go out of the operating room. And for that, you need negative pressure rooms. If it's not installed, there are some units that you could be installed later on to the ORs or even into the examination rooms, because ideally all ORs and examination rooms with this threat should have some kind of negative pressure, though they do not protect the individuals in the room. It is to protect the ones outside. So these are such systems, medical systems with ultraviolet lamps and HEPA filters. With such things being installed in the ORs, you can really decontaminate the air from the particles. And there are some smaller units, and to our clinics, we installed these while we were in the lockdown, where we do our examination and the endoscopies in the clinic. So principally then, while being protected, the aerosols that are generated, they're suctioned to that negative pressure systems. But the most important thing is actually the surgical team personal protective equipment precautions. This is imperative. And there are, I mean, I'm sure everyone knows now what is a FFP2 or 3 or N95 or N100, but the enemy is pretty small. And the resources all of a sudden have not been adequate enough. So instead of the surgical N95 respirators, in many places we needed to use other filtering face pieces or respirators or powered air purifying respirators. So these are, but if you use those, these are not surgical, they have valves. In order to protect the patient, you need to put a second surgical mask in front of that. These are reusable, so there is only one-time cost accompanied, but also the best protection is provided with the powered air purifying respirators, where you also don't use your lungs as the engine, and because of that, there is another standard there. If you are seeking for some, it's better that you have the TH3 standard. So for in the OR for the surgical team, if the patient is COVID negative, you use the surgical cap, goggles, gown, gloves, but the most important thing is the respirators, and we try to always get the P3 or the powered ones. If the patient is positive, then we additionally have water-resistant hazmat suit and disposable scrubs. The very important concept is only the ones who needs to be in the OR should be in the OR. There is, from the healthcare providers, there is a very nice study with almost more than 150 sinonasal skull base and open airway endoscopy procedures. By using the FFP3 systems, they have shown that there is no transmission of this virus. So based on this, we are using in our ORs the FFP3 or the PARPs. But it is also very important, as you can see from this study, the staff change rooms are much more dangerous than being in the crowds. Because these places are where you can get the aerosol while donning and doffing of the instruments. So we got to be really very careful. Another strategy is the safety protocols of the institution to operate in a safe environment. We need a complete new way of thinking for that, and the safety should be our number one priority. We always need to use the PPEs, and we also have started to open up the clinics since June 1st. And that put us into a different kind of chess game this time to protect ourselves and our patients, as Dr. Sama have explained. Another thing is that, unfortunately, this disease will be with us for some long time. As I mentioned, in Turkey, we have been around 1 month behind Italy, but now after opening, it's getting again a problem. So until everybody have a herd immunity or a vaccine comes, this will be a problem. So the safety protocols of at least my institution is the clinic access log. We ban all visits to the clinic. There is a mask obligation for everyone. We test 2 times for patients who we need to operate on, 48 and 24 hours before. We have, within the 48 hours, a thorax CT before we operate. And after the tests and having those, we put the patients in quarantine with no accompanying person till we operate. And we get from the patients additional risk consent. And as Dr. Sama have explained, we always try to defer or do the case selection and try to use the least invasive treatments. Because of the study that he already have shown, I'll not get into detail, but we don't want to put the patients into trouble also with such high mortality rates. Thus, perhaps we should not really restart elective surgeries that early. So how can I operate safely endonasally? First of all, not being inside is, if you're not a needed OR personnel in the OR, and you need to have the appropriate protective equipment. Constant suctioning seems to be very important in all surgeries, so that means a forehand surgery. We can avoid drills if possible, if we can use other instruments, but according to one study, it is not contraindicated. And if needed, we should employ drills safely with the good technique by using the coarse diamond burr and frequent irrigation. And we should minimize unnecessary drilling, do not activate outside the drill, and we should have protective barriers between the surgical field and the team. So it's also important not to cross-contaminate with the patient. So it's a totally new way of thinking. It's also very important to know that this is a neuroinvasive virus. Thus, we don't want to open the dura, so we should avoid intracranial penetration or a CSF leak. And when we do operate in the frontal sinus area, iatrogenic CSF leaks are generally in that area of the highest probability zone. Thus, navigation could be helpful by really marking the skull base. It could give some enhanced recognition with the augmented reality. And this is, although it is February 2020, it is good old times. Nowadays, if we want to operate, we have new precautions, new inputs, and it's totally a completely new reality. So I just want to share 2 cases that we have needed to...
Well, we're just a little bit short of time. If we've got time at the end, we might come back to those if that's okay.
Okay.
So thank you for that. That was really helpful, an excellent alignment of how we should proceed if we are going to operate, particularly endonasally. And I'll now pass the mantle over to Ioannis, who's going to talk to us about the place of the external approach.
So dear friends, as Anshul and Cem mentioned it, most pathological conditions of the frontal sinus requiring surgery can be successfully managed by endonasal procedures. There remain, however, a number of problematic cases that need a combined endoscopic and external approach or an external approach alone. So in my talk, I would like to give a few tips and tricks using external approaches. I would like to talk a little bit about the indications. And I would like to give a few recommendations regarding the COVID era. These are the most common indications for external frontal sinus procedures. You know, the neosteogenesis after a severe previous trauma involving the frontal sinus pathways, patients that have undergone multiple endoscopic procedures, of course, the frontal osteomyelitis. If their pathology is far lateral or in the supraorbital recess and is not accessible endoscopically, then of course we can use an external approach, and I will show you which is the best approach in these cases. Of course, major benign and malignant tumors, and in cases with an aesthetic correction of the forehead after a trauma, after a loss of the anterior frontal sinus wall, and also after a radical frontal sinus operation. Before we switch to an external approach, first we have to see the limiting factors for endoscopic extended frontal sinusotomy. And here the anatomy plays an important role. The narrow anteroposterior dimension and a very thick nasal peak narrows the distance between the nasal peak and the anterior skull base, making the entrance here of curved instruments and a curved burr difficult and increasing the risk of a CSF leak, of a damage of the skull base. If you see this picture, an hourglass configuration in the proximal part of the frontal sinus pathway is also very often related and associated with a higher risk of scarring, obstruction, and relapse of the pathology. And of course, everything depends on the experience and expertise of the surgeon and the availability to bring specialized instruments inside the nose. These are the most common external approaches that we use in the endoscopic era. And I would like to emphasize the mini trephination, especially in the COVID era, and the osteoplastic flap. External frontoethmoidectomy is in our days indicated in trauma cases, or also in a COVID era if we have a severe bleeding and we have to ligate the anterior and ethmoidal artery, then a small orbital incision can be very helpful to find the vessels and to clip the vessels. The cranialization is an emergency procedure in the majority of the cases, is indicated in trauma cases and in malignancies. Look, this case, and this is the external approach that I would like to focus a little bit also in the COVID area, the mini trephination. Anshul has mentioned it. Look, this isolated pathology is an aspergilloma with destruction here of the frontal sinus floor and extending into the orbit. And you see that I have performed here a type 2A drainage, and you see that a curved instrument, curette, and also punches, curved punches are also very helpful. The navigation system can be not only helpful in the endoscopic surgery, it's also helpful in external surgery in order to find the right place of our incision. And the mini trephination, you see, you perform a small hole, 5 up to 8 millimeters, and this gives you the opportunity to bring another instrument inside the frontal sinus and another endoscope. Of course, alternatively to the mini trephination, you can perform an endoscopic orbital transposition. But in the COVID area and also in the area of minimal invasive surgery, if there is no other pathology, I think that the mini trephination is the best solution for such a case. And there is also another statement that if you perform an orbital transposition, then you have to know that you need an experienced surgeon, you have to have strong skills in this area, but there are also limiting factors, and as a narrow anteroposterior dimension of the frontal sinus, and also a massive extension of the pathology into the orbit and into the supraorbital recess are limiting factors. So please think about the mini trephination, and this should be not regarded, the mini trephination should be not regarded as a procedure from the past. It is, especially in the COVID area, very, very helpful because in an acute frontal sinusitis, we can evacuate the pus, and in combination with antibiotics intravenously, we can solve the problem. We can flush the sinus with steroids to promote patency. And this is also a fast procedure in a high-risk patient. We had a patient in an intensive care unit, and this was a really excellent, a very fast procedure to evacuate the pus and to treat the patient successfully with antibiotics. Where should we place the incision? Be careful not to damage the supratrochlear nerve here and the supraorbital nerve, so you have to go here medially and here laterally in order to avoid the numbness of the forehead. If we perform, and if then osteoplastic flap is indicated, then there are three important factors. First, the appropriate incision, and second, what should we do with the frontal sinus? Should we preserve the function, or should we obliterate? And I think in the COVID area, we should avoid to obliterate the frontal sinus, and I will tell you why. And then another important factor is reconstruction of frontal defects. So first, the appropriate incision. I do not use such a bilateral eyebrow incision with a connection here with an incision in the glabella, because with this incision you cut the nerves and you have a numbness of the forehead. I use the coronal incision, and we do not shave the hairs in order to avoid the long-term stigmatization of our patient, especially in women. And note that an alternative in patients with alopecia or in elderly patients, an incision here in a forehead wrinkle provides also excellent and pleasant aesthetic results. So if an external osteoplastic flap is indicated, and you see here the indications, of course, a pneumocele is in the COVID area not an emergency indication. We can prolong and postpone these cases, but you see fractures, CSF leaks, benign tumors, we can also postpone them, but malignancies, we cannot postpone them, and also inflammatory diseases, and if they are not complications. I will prefer the Lothrop procedure in the COVID area. That means such in the cases of an inverted papilloma that is extended here in the supraorbital recess and destroyed the posterior wall of the frontal sinus, and you see here the pyocele and the accompanying pyocele, and here I would like to do a maximal drainage of the frontal sinus, a Lothrop procedure. That means removal of the frontal sinus floor from the medial orbital wall from one side to the other, preserving the cribriform plate. And this procedure gives us also the availability to go postoperatively with endoscopes inside and to diagnose an early recurrence, especially such in this case in an inverted papilloma case. So the obliteration, we do it in my department really, really rare, and we do it in the COVID area. There is in our hands no indication, because you have to drill all the mucosa here to remove the mucosa, to drill the inner layer. So if you can manage the case with a Lothrop procedure, I will go and perform a Lothrop procedure. In contrast, in the cranialization, this is in the majority of the cases an emergency procedure. You see here this case with the CSF leak, and you see in this case, together with the neurosurgeons, we have removed all these fragments, and then you have to seal After removal here of the mucosa, you have to seal the ostium, the frontal sinus ostium, the temporalis fascia, fat tissue, and we have supported also the dura here with synthetic lyodura, and then we have reconstruct with a neurosurgeon here the forehead, and this air will be resorbed after 2-3 weeks without problems. So that means the indications for cranializations, and in the majority of the cases, emergency indications, so we cannot avoid to perform a cranialization. Let's say a few words about the causes for frontal defects. Here, a trauma, tumors, infections, of course, congenital lesions, and the benign tumors can be prolonged and can be postponed, but osteomyelitis, malignant tumors, and a severe trauma should be done immediately. And we do it in a trauma unit together with our neurosurgeons. But if we harvest and if we use grafts, I would like to tell you what are our favorite material. These are calvarial grafts, autologous materials here from the parietal area, and you have to go 2 centimeters lateral from the midline in order to avoid the superior sagittal sinus and avoid also the sutures of the cranium and here the temporal line, because on this area the bone becomes thinner and the diploid becomes thinner, and there is the higher risk to damage the dura. And if you need here to reconstruct the forehead, you need a curved graft, and therefore you have to go here horizontally in the parietal area. If you need a more straight graft, especially for the nose, then you have to go here vertically in the occipito-parietal area. And you can use these grafts as a complete graft, or you can split it. It depends on the thickness of the bone and the diploid, and therefore a CT scan preoperatively is mandatory. You see here such a case. She had 7 previous operations, and so you see this bad incision here, and this scarring of this incision. Then she had an osteomyelitis. She lost here the frontal side. And now she had also piocele with an orbital involvement. And this is a case that we cannot wait. We have operated her years before. I will not go in details in the incision. What I would like to emphasize is first, we dissect and scalp flap up to the supraorbital rim, and then we dissect a pericranial flap 1-2 centimeters above the borders of the frontal sinus. And this flap, this pericranial flap, is very, very important because this provides a blood supply of our graft and also of the anterior wall of the frontal sinus. Therefore, we try to left attach the bone on the pericranium if we perform a classical osteoclastic flap. And then what we are doing is here we have removed the piocele, then we have drilled out all the mucosa. We have sealed then the frontal sinus here with temporalis fascia, and then we are going to the defect. We measure the defect here, and then we go to the parietal area, and with a small cutting burr, we outline the size of our graft, and then with the help of an oscillating saw, we remove and we dissect, and with a chisel, of course, we dissect our graft. Here it was an calvarial split graft. You see it here nicely. And the bleeding from the emissary veins can be easily managed by using bone wax or by using a diamond drill. And then we go to the recipient bed and we fix the graft here. Years before we used microplates, now we use sutures. We have made the experience that the blood supply, if you preserve here, the pericranial flap is excellent, but our patients have to wear a headband for 6 weeks postoperatively. And in order to avoid here irregularities between your graft and the adjacent anatomical bone, anatomical structures in the bone, we cover these borders with temporalis fascia and fibrin glue. You see it here very nicely. And also here the 3D reconstructions of this lady. Here the post-op. Here the post-op, you see the improvement of this depression here. And here in osteomyelitis, you cannot wait. We have to operate these cases. You have to remove here the sequester and then reconstruct with a galvarial graft. So this is the, let's say, ideal material that we use. But there is a question, because if we have in the COVID area to drill, and we drill a lot, we use an oscillating saw, is the titanium mesh plate an alternative? Of course it is. And in cases that, that are positive, or in cases that we are not sure, or in cases that there is a suspect COVID-19 infection, then we can use a titanium mesh plate. But please don't use an implant in these cases if you have to put the implant in contaminated spaces under irradiated skin and after a foreign body reaction against alloplastic material. We see in our country a lot of patients from the neurosurgeons that they have put Balakos and reconstruct Balakos, and this Balakos is very close to the frontal sinus mucosa, and then the Balakos is infected and all the bone is infected. So in these cases, I will prefer, with all the protective equipments, the galvarial grafts. In the other cases, the titanium mesh plate is, of course, a good and very fast alternative. And this is my last slide. And so we have not to forget the external approaches. We see how important, and Anshul has also emphasized it, the mini trephination is in our days in the COVID area, because it is a really fast and definite option in high morbidity patients. Think about the patients in the intensive care unit, and also in complicated cases. And that means we should include the external approaches in our training programs. Therefore, we participate in our trauma unit together with the maxillofacial surgeons and the neurosurgeons. And I think also after our endoscopic courses, we can go with our younger colleagues and try and teach the external approaches. I would like to thank all our members, all of you, for being with us the last months, the last difficult days. And I hope to see you in Thessaloniki in 2021, hopefully in May next year. So thank you again, and congratulations for the ERS board and for you, so especially for the organization of these webinars. Thank you.
Ioannis, thank you very much indeed for that. A whistle-stop tour through the external approaches and some really important tips there for utilizing particularly the minimally invasive external approaches, as you might call them, for safety reasons. I think we've got a number of questions, so I'll pass over to Pavol, who's kindly going to read those out for us, and we'll direct them into each of the faculty as required.
Thanks again for fantastic presentations. Yes, we do have some excellent questions. Now, the first one is on the spot when it comes to minimal invasive procedures. What about the frontal sinus and balloon techniques? Would you consider this now more frequently than before in the COVID-19 era? I think it will be probably for all of the speakers. Ioannis?
I think this is a very, very good question, because the strong indications for the balloon are the patients in the intensive care unit and the patients with an acute complication of frontal sinusitis. I will be very honest, it's too expensive for my country. We use it not in a routine, we use it only in selected cases. But this is really an issue for discussion, I think, for an intensive care unit. But you have to, I will go more for a mini trephination, because you have to go also, if you use a balloon through the nose, maybe you have a bleeding, maybe, you know, I think we need a fast and very precise procedure if we manage a complication and if we manage a patient in the intensive care unit.
Any other opinions on this? Cem or Anshul?
For which indications actually? I mean, that would be important for me. I mean, you at the end you also go endonasally to utilize the balloon. So I mean, it's not. It's a very good question actually, but the cost is a problem also in my country, and we also go through the nose endonasally, and normally I don't use it that much, but I mean it should be discussed case based. The judgment should be made the case based. It should be also in the list of armamentarium. Okay, I have nothing against that, but it should be decided case based.
Now, I will ask actually Anshul the next question because of the sake of the time. Now, in light of increasing waiting times for the surgery, would you change your approach to the medical or conservative management of patients with the frontal sinus disease? Would you be more aggressive?
Yes, definitely. I think in this current era where we have to be very selective and very precious, theatre time is extremely precious. I would really be extremely aggressive with my medical therapy, probably proportionally greater. Even certain situations, you look at a scan and you often
aggressive with maybe.
Sorry, Paolo, I think you're just cutting in and out. So I think there are probably certain situations you look at a scan and you think that is unlikely to respond medical therapy. However, I would now aggressively try medical therapy. And I showed you a couple of scans where you can reverse what may be thought to be a surgical disease with really aggressive medical therapy. So I'm much, much more intensive with my medical therapy now, yes. Sean, I think Paul might have been, yeah.
You still there, Pavol? No. Okay, so our next question is, does the panel routinely use CT scans to exclude COVID before surgery? Can I have a one-word answer, please, from each of you? Anshul, what do you use?
No.
No. Okay. Ioannis, no.
No.
Cem?
If we are operating, it's a requirement in my institution.
Okay. So in the UK in general, I don't think we're tending to do so. Pavol, next question.
Yes, so the next question will be, actually this question is for us too. What Anastasia Rachmaninoff would be interested, what are the precautions prior to surgery and whether actually we are performing the elective cases in UK? So, Sean?
Well, I suppose the answer to that is that the situation is changing very rapidly. We've gone from being what you might call a COVID-heavy era into a COVID-light era. And we have patients who are becoming, I suppose, increasingly concerned about their condition and are beginning to ask, is it time for me to have surgery? I think we're still in a stage where we really need to have a proper consent process with our patients, and our three speakers have outlined that beautifully this evening. And the risks in the post-operative period, if you catch COVID, are potentially catastrophic, and that needs to be brought into the consent process. So I think, in summary, really, we're beginning to do more. We're beginning to do some routine cases, but we're very much being very careful about consenting patients, not just in the risks and benefits of surgery and the anesthesia, but the risks around COVID, although trying to minimize that risk to the patient as much as possible.
And now when it comes to the last question, I think for the sake of time,
yep.
Whether you would use any grafts to cover the denuded bone after draft 3 or long-term stents. Anshul, please.
Well, I think grafting is the key to any kind of frontal sinus surgery. Mucosal preservation we always knew was key. if you're going to start doing any more extensive procedures, grafting is the key. That's the only way you're going to sustain. And I do not see any reason in the COVID era to actually change that philosophy, because you're not increasing the COVID risk by moving mucosal grafts around. So I would definitely suggest that if you're going to do something more than draft 2B, where you have denuded run, cover it with mucosal grafts.
What about silastic sheets? As in Australia, is very popular.
Long-term silastic sheets has no efficacy at all. I've removed more than I would like to think about.
Not long-term, I mean, just for the time until...
Temporary silastic sheets, once you put a mucosal flap for a week or 2 weeks, is entirely acceptable. You have to consider the risk that you put yourself into when you remove that silastic sheet, because any instrumentation now that we have to do in the post-operative period is a potential high-risk maneuver. People have started to actually, rather than see them at 1 week, now see them at 3 weeks rather than seeing them at 1 week. So you have to be, if you're going to be doing this, you have to be in an appropriate environment with appropriate protection when you are going to be doing a post-operative care.
Absolutely.
Ladies and gentlemen, I think I'm going to have to interrupt. I'm very sorry to say we are out of time. I'd like to thank all three speakers and Pavol for an excellent session. We've touched on many different areas of frontal sinus surgery and the current pandemic. I hope you've enjoyed it. I apologize, it's gone on a little longer than anticipated. I'd like to welcome you to the combined Euphoria and ERS webinars, which are taking place on the 22nd, 23rd and 24th of this month, and these are essentially around the new EPOS 2020 guidelines. So I'd highly recommend those to you. More details are available on the ERS website, and you'll be getting shots about those through email as well. And one last plug, our next dedicated ERS session is going to be on epistaxis on July the 2nd, which I'll just remind myself, I think is a Thursday. So thank you very much again indeed, everybody, and stay safe.
Stay safe. Thank you very much.
Stay safe.
Thank you.